Good morning, everyone, and welcome to our webinar, Mutual of Omaha Underwriting Guide Changes with Ames Mike Anderson and Mutual of Omaha's Chris Klement. Today's webinar will be recorded and then later posted on our website. This does mean that all attendees will be automatically muted so that we get a quality recording. If you have any questions, go ahead and type them into the chat box and we'll try to answer them throughout the presentation. But if we're unable to get to all the questions, we'll have a member of our marketing team reach out to you individually to make sure you get that answered. Before we get started, we'd like to invite you to join us for our next webinar on Tuesday, June 10th at 9 a.m. Pacific Time. Join Ames Mike Anderson and GTL's Greg Esposito for Double the Impact, GTL's Precision Care Cancer Coverage by registering at yaim.com/training. And with that, I'll hand it over to Mike so that we can go ahead and get started. Take it away, Mike.
Thanks, Jordan. Thanks, everybody. Appreciate you all joining us. Really pleased today to have a couple of the Mutual of Omaha underwriting crew that I've worked with extensively for a long period of time. Not only do we have underwriting manager Chris Klement, but we've also got a veteran underwriting consultant, Mike Weingard, who's been around for a long time. Mike and I spend a lot of time on Mondays talking about college football happenings and such on Saturdays based on the Midwest. Also from Mutual of Omaha sales team joining us this morning, we've got Amanda Blackburn, who's the sales director and has worked with us for almost 15 years now. And then Maria Laura Rivas, who's the behind the scenes wizard who fixes things here, there, and everywhere and makes it possible to keep all the pieces, parts moving forward. We're going to spend some time, as Jordan said, and talk about the changes that just got approved and just got put out to the field in the underwriting guide. Some interesting stuff that I think you're going to enjoy the opportunity to make use of. And then we're going to look at some other things that are going on in terms of trends, what we're seeing in the market, why we think that's happening, and what's going to continue to happen moving forward. So with that, I'm going to stop. I'm going to turn it over to Chris and take it away. Chris, let me know when you want me to change slides. Looks like you're self-muted, Chris. So I'm going to click and unmute you here, but just make sure you're not muted on your end.
There we go.
All right,
how about
Chris,
now?
Now you're good to go. All right. Sounds good.
I'm slow, but I get there. So
No
first of all,
problem.
I appreciate the invite. You know, it's always wonderful to have these sorts of conversations. I really love the calls where we talk about our underwriting guidelines. It is something that we do each year. We always take a peek at our guidelines. You know, one of the interesting things about medicine is that technology, advances in science, all those different things that sort of come into play means that impairments that once were very scary for us are things that we can consider now. So with that in mind, we always sort of have our nose to the grindstone looking for opportunities to liberalize our guidelines. Next slide, please. All right, so today we're going to talk about, we're just going to go briefly over underwriting requirements. In other words, what sort of things are we looking at based on to make a final determination. The bulk, we're going to talk about those guideline changes. We have some substantial ones. It's not low-hanging fruit. We've actually made some changes that we think are going to move the needle. And then we have some other updates, other projects that we're working on here at Mutual of Omaha around our underwriting processes. Next slide, please. All right. So I don't know, is Mr. Weingard, are you on, up and ready?
I sure am. All right. Underwriting requirements. And the first one is MIB and medical claims data are ordered for all applicants. And that also includes the farm report that we've always gotten. We are also, number two is we are no longer auto ordering medical records. They're only ordered at the underwriter's discretion. And that's based upon our review of the MIB and medical claims data. It can either be stuff we find in there or just lack of information too. If we don't find it reliable or there's like no data at all on the older people, we tend to order APSs if we don't feel comfortable with that. Number 3, for clients age 59 and younger, we will no longer auto order phone health interviews. Those are only ordered at the underwriter's discretion. A lot of times now that might be just to clarify a couple things that we find in the medical claims data or pharmacy reports. So
Yeah,
that
let me jump in
helps
there
out.
just for 1 sec. There are also situations where if somebody has a trigger, and by that I mean, so for example, let's say that you had somebody under the age of 60, but maybe had a stroke 3 or 4 years ago. In that particular case, we would order a phone history interview with specifically that cognitive screen. We just want to make sure that their cognition is in line. We're hoping to see that there are no residuals from that stroke, as an example. So there may be some triggers based on health history where we would order a cog screen for somebody under the age of 60.
All right, thanks, Chris. And then number 4, for clients age 60 to 64, we can continue to auto order interview. Medical records are only at the underwriter's discretion. And lastly, for clients age 65 and older, we will order face-to-face assessments. Medical records are only ordered at the discretion of the underwriter. So again, that goes back to based upon our review of the MIB medical claims data and farm report. If we're pretty comfortable with that, a lot of times we're not having to order medical records, so that we found that's working pretty well for us.
Excellent. All right, so how the business sort of rolls out. What our issued business. So when we look at the block of cases that we've been able to issue, about 74, 75% come in at that select rate. Approximately 18% qualify for that preferred health discount, which is an additional 15% off of our select rate. And then about 8% come in at class 1. Now we do have a class 2 rating. We don't use it very, very often. It's more sort of designed for specific impairments, like the combination of diabetes with atrial fibrillation, for example. There may be situations where for some of the blood disorders, you may see a class 2 come across the board. So it's not something that we use very, very often. It's less than 1% of the time. Some of the competitive advantages that we feel we offer, number 1, direct access to the team. I mean, not talking about webinars or anything like that, but if you have a case and you have some questions, you have the ability to call the underwriter and discuss the case. Especially if you think about the old days where apps were taken, in the kitchen. You guys are our eyes. Certainly, we know more and more things are happening online, when you're displaying options and those sorts of things. But, at the end of the day, we rely on you, and you can convey that information directly to the team. It also holds true if you have questions about an offer that we've made. We certainly try to provide those details on the front end. But if you have any follow-up questions, of course, you have the ability to reach out to the underwriter, actually work the case. Another thing that we do that we feel offers us an advantage is that we're willing to consider prior declines from other carriers. We do recognize that guidelines do vary carrier to carrier. We know that weights for certain impairments may differ from carrier to carrier. So certainly if somebody's been declined by one of our carrier or one of our competitors out there, definitely pre-screen the case with us. If you have a copy of that decline letter, share us. Certainly you can redact the individual's information, their personal identifiers, but we can certainly talk about those concerns outlined in the letter, and we can let you know if it's something that we would consider or not. In other words, if you've been declined with another carrier, it's not an automatic decline with us. And then, of course, really kind of the big topic of the day is that we do review our underwriting guidelines on a regular basis. We're not beholden to a reinsurer. Our guidelines are what we come up with based on feedback from you in the field, as well as what we're seeing in the industry, but also we look at our claims data. And then, of course, we run these proposals past our medical directors. Ultimately, we're looking for opportunities to make offers. At the end of the day, our job is to put business on the book. So that is something that we feel that we do a good job at. Next slide, please.
Yep, they do a great job of it. I just want to jump in here for just a second. One of the pieces of this direct access to the team, it's actually built into the application. It's called the authorization to release information. And over the last 15 years probably or so, we've seen a huge uptick in what we call generically undisclosed health from the clients, where they don't give a full and thorough recitation of their health history to the agent. By making use of that authorization to release information piece built into the app, that enables you and I, the agents and I, to get on the phone with Chris or with the line underwriter that handled the case and find out just exactly with some restrictions, but they're real small restrictions. But it allows us to find out exactly what it was that led to the decline that wasn't disclosed. And then not a ton of cases, but enough cases to make it worthwhile, we're able to work with the underwriter to figure out a way that we can thread the needle and get something accomplished or get additional documentation in, so that we're able to get this thing corrected and go from having something postponed or declined and actually have it brought in line and able to move forward. So anyway, go ahead.
Yeah, that's a great point, Mike. Thanks for bringing that up. I do a lot of these things, and I always seem to forget talking about the old ARI. That's what we call that form internally. So definitely a great point. At the end of the day, if we can't offer coverage, that doesn't mean that we don't want the individual to have coverage. So by completing that form, we can give you every piece of information that ultimately led to the decision, which means that if we can't offer, at least you can shop the case and ultimately hopefully find a solution for your client. With that, I'll pass the baton back to Mike.
All right, underwriting guideline changes. I think you'll find this is the one that has the most impact. We have changed our guidelines for family history dementia. For somebody that's a single direct family member with familial dementia or Alzheimer's, still benefits are still capped at $300,000. But a single direct family member with a non-familial dementia diagnosed at 80 plus can now get a preferred rate and no benefit limits. Non-familiar would be somebody that's had a stroke, head injury, or something similar to that. So it's not like Alzheimer, or have several family members that have had got dementia. Then 2 direct family members with familial dementia or Alzheimer's is a decline. And 2 direct family members with non-familial dementia diagnosed at 80 plus is select, with no benefit limits.
Yeah, and one thing that the slide really doesn't convey, and that's kind of my fault for not being super clear here, but going back to line number 2, where it says a single direct family member with non-familial dementia diagnosed at age 80 plus, that really should read a single direct family member with a family history of dementia diagnosed at age 80 plus. There is the possibility for preferred. So regardless of the root cause of the individual, in other words, the parents or the siblings' dementia, we're going to offer them potentially preferred rates, assuming, of course, that all other history is fine, if the diagnosis age is 80 or older. So if mom developed dementia at age 84, you have preferred is on the table, and there are no policy limits capped. If the individual has non-familial dementia diagnosed under the age of 80, so this could be mom was diagnosed with dementia at age 64, if we know that it's due to some sort of vascular issue, perhaps it was related to head trauma, stroke, what have you, we're going to treat that person as if they do not have a family history of dementia. Any sort of familial dementia, kind of use layman's terms here, is sort of anything that has a hereditary component, will continue to have that policy capped at 300,000, unless, of course, that even if there's that hereditary component, if they were diagnosed at age 80 plus, we're going to disregard it. I suspect we'll have a lot of questions around this. It is a little bit confusing, but it's a huge liberalization on our part. All right. Another big change that we've made is in the osteoarthritis arena. So really what we have here is what's going to show up in the next release. This is what we're going to have for a arthritis section. Now keep in mind that this differs from disc disease, herniated disc, etc. Anything that's back or neck related is going to be in those specific sections, and we haven't made any changes there. So really what we're talking about here are your shoulders, your hips, your knees, your ankles, etc. Previously, any sort of osteoarthritis in any joint, again, we're not talking about the spine. If there was severe arthritis anywhere in the body, it was a decline with us. And what we're saying now, that if an individual has a single joint severe, and it's been stable for 12 months, and under these caveats, again, we don't want to see excessive narcotic pain medication use, no pending surgery or additional treatment planned, no handicap placard or no ongoing steroid injections, we're going to consider this person for coverage. And for previously, this had always been a decline, so, severe. It will also sometimes present as bone on bone. You would sometimes hear the term advanced. Those are all sort of interchangeable terms for severe osteoarthritis. So if it's limited to one joint, and there are no significant comorbid factors, we're going to consider this person for coverage. And as you can see here, there are a number of different ratings possible. So the IC really stands for individual consideration, which means that there is a possibility for select. You're not going to get a preferred, which I think, there's no surprises there. But there may be a possibility for select. More likely, we're going to see a class 1 or a class 2 in these sorts of settings. And a lot of it's going to depend on the case holistically. So for example, if you have somebody that's on the heavier side, maybe they have a class 1 build, but they have a single severe in one knee, they're probably going to be a class 1 or a class 2. We know that that weight is causing, perhaps even created some of those issues within that joint. And also when somebody is on the heavier side, there is the possibility that other joints may be impacted. Now, they may not yet be severe, but certainly obesity may cause the other knee to go or the other hip to sort of become compromised down the road. So, again, we want to be very, very clear on or very careful on how we quote these going forward. If the individual has had an MRI or a X-ray in the severity of what one single joint is severe, otherwise very well managed. We see it on occasion where we have a gentleman that'll have osteoarthritis in one knee and doesn't require any sort of care at this point in time. His pain tolerance is pretty well. There are no limitations. I mean, that's somebody that we would come back at as a select. Again, when you start adding some of those comorbid factors, you're more looking at a rated situation. Another thing that I wanted to point out here as well is that the weights that we're having for these injections now, we're really looking at this as more as a 3-month wait as opposed to a 6-month wait. Now, again, back is different. We're not making any changes there, but we do feel that within 3 months, if we know that that injection has worked at that point, then we're probably going to be in a good place. And again, we would consider that person select, or depending on other factors, it could be a rated case, and thus the IC listed. No really significant changes otherwise within our osteoarthritis criteria, but just know that, osteoarthritis is one of those things when we compile our top 10 lists, it's always up there in the top 5 or so. And in most situations, it is due to somebody having a single joint with severe disease in it. So I do expect that going forward, we may see osteoarthritis as a reason for a decline or postponement to perhaps be in the 5 from 10, or maybe drop out of the top 10 altogether. Usually that's what happens, is we see that single, what we had seen was that single severe disease in a specific joint, and we ended up declining. So really think that this is going to be a pleasant change for us as well. Next slide, please.
All right, and we've had some guideline changes for strains and sprains. Mostly you'll find here, it's just we remove the waiting period. So as long as you've completed treatment, we can look at like acute issue, fully resolved, no underlying arthritis or other chronic issues, can get a select, or excuse me, a preferred rating as soon as treatment's ended. And it also applies if it's an acute issue, It's resolved with PT, like post-op PT, you can get a preferred rating right away. If it's recurrent, stable, and no additional treatments expected, we can go with a select rating right away. If it's secondary to a chronic issue and currently stable, we'll select or rate for the underlying issue. Something like that would be like a back sprain or something like that. We would defer to our back guidelines.
Mm-hmm.
And secondary to a chronic issue, post PT, stable for 3 months, again, select, and we'll look at the underlying issue. Like, when I think of this, I really think of like somebody's had like some tendonitis in the elbow, like once they completed treatment, we can look at them. Before our guidelines, if they had an injection, we'd have to wait 3 months. Now we can look at it right away. So.
And really, that was the reason for creating this section, is that, not all PTs or not all impairments that require PT are created equal. And when we have situations where it's an acute issue, maybe a little hamstring strain or something along those lines, I mean, realistically, what is the chance that this person's going to require ADL, or they're going to lose their ADLs in the short term? It's really not going to happen. These are acute issues. People bounce back pretty quick. And we felt that requiring them to wait an extra 3 months once they've already been released from care really didn't make a lot of sense. We know that more and more PT is almost treated like chiro care to a certain degree. It's much more liberal and much easier to get physical therapy these days than in years past. And I think we can probably thank COVID for that. When all the gyms shut down, doctors were prescribing folks with physical therapy to sort of take the place of going to the gym when the gyms were shut down during COVID. So we had to sort of look at our guidelines and add a common sense approach to them. These acute issues are going to lead to claim long term, especially when they're not recurrent. So with that in mind, to be able to have somebody, who strained their hand or maybe had a little rotator cuff strain, once they're back up and running, preferred's on the table. Next slide, please.
All right, and the best of the rest guideline changes, you won't see a lot of these. Probably the biggest one here is we now will consider people that have had white matter changes on MRI. We have to have our medical director look at them, but I've seen quite a few of those where we've been able to issue them here recently. Another one is we're rewarding the people that have had diabetes for 20 more years that have had well controlled and have not developed any complications. Previously, we just always declined those. And we're also allowing naltrexone for pain, but we'll underwrite for the underlying cause. Previously, it was an auto decline if they weren't taking it for weight loss. Another change we had is factor 12 was previously a decline. Now we're able to consider those select. We don't see too many of those, but maybe we will now. And then we also now, even though this is kind of how we already handled the disease modifying drugs and biologics, generally we handled those with a class 1 because they're usually taken for rheumatoid arthritis. But now if they're taken for other conditions, we'll also rate those class 1.
Yeah, and part of the reason behind that is that these medications, they do a wonderful job. But if you think about it, these autoimmune conditions, really, these medications stop your body from attacking itself. So rheumatoid arthritis is your body is having an immune response to something, and it's causing, issues with your hands or what have you. It's your body is attacking itself. So these disease-modifying drugs sort of calm your system down, your immune system down, so that it's not attacking you, which means that these conditions such as rheumatoid arthritis or psoriatic arthritis sort of calm down and things stabilize. Now, the risk associated with it is number one, those impairments can be kind of scary. But number two, once things have calmed down, you typically have to remain on these drugs. And there are risks associated with your immune system at that point, because you had to reduce or sort of tell your body to stop attacking itself. That also means that should you get some other sort of issue happen to you, your immune response is compromised, which means that a cold that you may experience while on these disease-modifying drugs versus somebody who's not on a disease-modifying drug. The cold that person may have, they may react to it differently. And any sort of condition or thing that goes on when you have a compromised immune system means that typically you're going to feel the effects a little bit harder, and typically will last a little bit longer. So that's really the reason why we have this class 1 rating associated with these specific medications.
Talk for a second, Chris, about medications used off-brand. A lot
Sure.
more of that now than there was a few years ago, and just to make sure that the folks on the call understand what kind of documentation you want when somebody's taking medication X, which is for condition Q, but they're taking it for, condition Z, whatever. It's more of a deal than it ever has been in the past.
Yeah, absolutely. Kind of the first medication that was out there that really sort of became famous for being able to be used for a number of different conditions was prednisone. At least that's the first one that comes to my mind. Prednisone's been used for everything from asthma to arthritis. It's an anti-inflammatory, and really the disease process, or a number of different disease processes that really sort of hit you and cause inflammation. So prednisone was a medication that was able to reduce inflammation throughout the body, which meant that they could use this medication for a number of different things. So that's kind of like the first one that sort of came out there. Now, with that same sort of mindset, and more to Mike's point, is that there are a number of medications out there, and really naltrexone, although this is relatively new, really the big ones out there right now are those ones where you would normally think they're used for diabetes, but they're actually can be used for things like weight loss. You have naltrexone that was created initially. It came out as a medication to assist those folks in recovery, meaning that doctors used to prescribe naltrexone to people to help them get off alcohol or drugs, or to ensure that they don't relapse, those sorts of things. But we find that these particular medications can be effective for other things. And so doctors reach out and say, you know what, let's try this. And oftentimes they're able to sort of navigate or create sort of almost like a little cocktail, if you will. Perhaps it's a poor term to be using when we're talking about naltrexone, but these combinations of medications overall just sort of limit the overall risk. And so like anything else, you can attack a disease process from many different angles. So ultimately, what we want to see when we see a medication being used off-label, the more details you provide, the better. We see that a lot of folks, we know that semaglutide, for example, is a medication that a lot of people are using right now. It's one of those injectables that was developed to treat diabetes that people are using for weight loss. If you have somebody that's on the heavier side, one of the things that you may see is that they're using something like semaglutide, Wegovy, et cetera. There are a number of these. They're GLP-1 inhibitors or something like that. I don't remember exactly the exact term, but what we want to see is that we want to, when we see something like this on the application, we want to be assured that it is being used to treat one specific issue and not a litany of issues. So for example, going back to the diabetic, you could have somebody with diabetes that needs to lose weight, so they're on a semaglutide simply because it treats the diabetes as well as assists with weight loss. So when you see somebody like that, ask them. I would still ask, even if they insist it's due to weight loss, ask them if they've had an A1C done. And if they have, ask them what it is. Sometimes one of the things that we may run across when we run med data, because we look at med data on everybody, as Mike sort of outlined earlier on that one slide around requirements, is that sometimes doctors use weird billing codes to ensure that an individual will have that medication or treatment paid for. So you may see a situation where the individual's using semaglutide for weight loss, but we look at med data and it may represent or show that there is some diabetes as well. So just ask those questions. When you see that a medication being used for a number of different things, ask your client, say, hey, I know that this particular medication can be used for, it can be used for asthma, and it can be used for arthritis, and it can be used for other things. Make sure that you ask them to rule out some of those super scary things. At the end of the day, if somebody's on semaglutide and they have diabetes as well, if it's well controlled and they're continuing to lose weight, we're still going to offer them coverage, but at least this way there's no surprises.
Talk for a second, Chris, about, we've gone through all these conditions and select and select and select and select. Talk about stability and conditional stability and the kind of value that Mutual places on that and where it fits into the equation, because there can be disappointment if the agents are not aware of where it is things need to line up for that. So.
Yeah, absolutely. Most conditions out there have some sort of stability period. Certainly, the things like, with thyroid or high cholesterol, at the end of the day, you started simvastatin last week. I really don't care. That's good for you. But at the end of the day, there are a number of different things out there that do require stability period. And you do see it more and more in situations where it's a new onset of something. So it could be everything from a new onset of anxiety to, maybe you developed arthritis in your knee. We like to see that whatever therapy is being initiated at that point, at time of diagnosis, we want to make sure that that medication works. Now, there are some situations where some meds out there can cause weird things to people. Ativan used to be a big one where some people would take it to assist with sleep or something along those lines. And then all of a sudden, some people would have a side effect. And one of the I shouldn't say it's common, but one of the known side effects for Ativan is that people start to sleepwalk and they would, not remember anything that they said or did during that period. They would wake up in bed and perhaps be refreshed. I don't know, probably not. But it would be a situation where meds can act with you in such a way where maybe you need to change that medication. So that stability period really sort of reaffirms and reassures us that whatever therapy is being worked on or whatever sort of therapy is being used at that point in time is actually working and is beneficial. There are some people that may have an allergic reaction to a medication. Think about those medications where you see the ads on TV, and they talk about, maybe it's something used to treat Crohn's disease or something along those lines. And they talk about this new med because they want you to go to your doctor and say, hey, I want to try that med. But also, if you think about it, when you see those commercials on TV, they always end it with a huge list of different things and different complications that may happen, including, explosive diarrhea seems to always pop up. I don't know why, but it does. But there can be a number of side effects that can be problematic. And so having a specific weight, there's different weights for different conditions, but it really are all just sort of focus, or I shouldn't say focuses, but all the end result is we just want to make sure that whatever therapy the individual is using actually works and there are no side effects and no complications around it. Now, the next question I almost anticipate here is, what if somebody has a condition, they've been on a medication for, let's say, 3 years, and now they're talking about reducing that medication? And Chris, what happens in those cases? Are you going to postpone it until till we know if it works or not? No, I want to reassure you there that it's very different when you're changing a medication or increasing a dose of a medication versus reducing a dose of medication. Nobody wants to be on a med if you don't have to be. Why put these chemicals in your body if you don't need to? So if you have somebody, maybe let's say they have a history of depression, and they've been on Wellbutrin for 3 or 4 years, and it's done wonderfully for the person. It's been, night and day. And now they're thinking about, on top of the fact that I'm stable with this medication, but I also, have been, working with a counselor, and I have these different therapies or different strategies that to apply should I feel escalated or whatever the case may be. Let's try reducing that med. And so when you see that somebody's having a dosage reduced, I mean, the same would hold true with like high blood pressure. Let's say your high blood pressure is extremely well controlled, you've lost some weight, and they talk about reducing that med. We know ultimately, and the reason why we don't care about it too much is that should something happen, let's say in that high blood pressure person, let's say their blood pressure, they're off the med and their blood pressure start to spike up. What are they going to do? They're going to put them on the high blood pressure med again. They already know what dosage works, so there's not a lot of risk there. We know that as long as there's monitoring in place and the doctors and the medical providers are saying, okay, keep on reducing that med, things are going well, we're going to be okay with it, knowing that should something happen, they're going to revert back to that dose that was working for them previously. All right, so what's up next? So one of the things that we've been trying to do over the past few years, I mean, we've always done it, but we've made huge strides in cycle times with things like med data. We've had some pretty good luck with ENOA as an APS vendor. We're not sitting on our laurels here. My goal is, if at all possible, I would love to see our lead time on cases, our cycle time, if you will, from app in to app out. I would love to see it consistently, right around 25 days. We're currently at 35 days. Pre-med data, we are at 45 days. So we're making progress. We're making great progress. But with that in mind, we're always looking for different solutions out there to see what we can do to improve our cycle times. Now, one of those is electronic health records. Now, we had done a rudimentary pilot with electronic health records about 4 or 5 years ago, and it just didn't work for us. Really, the hit rate really suffered, and a lot of the special authorizations that were required for it really didn't work. So we tried it. We piloted one once. It was with a different vendor, and it just didn't work for us. Well, time has changed. With the advent, well, I shouldn't say with the advent, but more and more technology is just becoming to the forefront when it comes to just data in general. I tend to think that all companies now are just really data companies more than anything else. So with the more access that we have with data out there, we figured, let's sort of dip our toes into the EHR space again. Now, the wonderful thing about EHRs as a whole, as you can see, they're electronic health records, is that they really are, if you're reviewing them as the underwriter, it really looks like a set of medical records. It doesn't, it doesn't look like med data. It includes labs, which med data doesn't. But it also removes some of the white noise that you have with medical records, meaning that certainly, sometimes you can have some additional information in there that really doesn't matter or isn't relevant to the case. And it sort of removes some of those pieces. Now, in this particular case, also, EHRs have a fixed cost associated with them. Medical records can fluctuate. So our average APS cost is around $75, and each year that goes up and up and up and up. I actually had some cases not too long ago where the vendor reached out to me and said, hey, Chris, I need you to approve a fee for these sets of medical records. And I said, okay, well, what's the fee? It was $1,600. Well, we're not going to pay $1,600 for a set of medical records. So like anything else, we're looking at different ways to get that information. So med data comes to us instantaneously. We press the button, boom, we have their med data report. EHRs aren't as fast as that, but they're a heck of a lot faster than medical records. Usually you can get information when you request an EHR within 48 hours. And the hit rate associated with it now is up to about 60%. So what we're doing now, what we're looking to roll out at the end of the month, I'm hoping towards the end of the month, is that we're going to put a process in place where we don't order medical records anymore. We will place the order for electronic health records through ENOA, who is our APS vendor. And if it's a no-hit situation, which will be like 45% of the time, they will automatically pivot to medical records. So let me give you an example. So Dr. Smith is an individual's primary care physician, and unfortunately, med data didn't give us enough information to make a decision. So the underwriter determines I need those records from Dr. Smith. So the underwriter will reach out to the case manager and say, please order the EHR from Dr. Smith. And so the case manager is going to go out to eNOA, place the order for the EHR. In other words, they're going to request electronic health records from Dr. Smith. And eNOA, if they don't get a response within 48 hours, they will automatically change that response from an EHR to a request for medical records. There's no action required on your part. There's no action required on the case manager's part. They're going to automatically do that after 48 hours if we don't get a response. Now, what we're negotiating right now, and I believe what's going to happen is that when these EHRs do come back to eNOA, they're going to screen them for us. And if it's PT notes from 3 years ago, they're going to say, you know what, the underwriter needs more than that. They will automatically pivot to those medical records if the EHR is deemed to be insufficient. So we're pretty excited about that. Again, getting the equivalent of medical records within 48 hours or so is going to be huge for us. Usually our cycle times on cases where we needed medical records usually ran around 35 to 40 days. In situations like this, if we can take 50 or 60% of those cases where we ordered medical records and instead go down the EHR path, I mean, we're talking about significant cycle time savings there. So we're very happy about the ability to do that. And we love the fact that we can place one request, and either way it goes, be it there's a no hit for the EHR, it'll automatically go to medical records and with no activity required by the case manager. So we're really excited about this. Another piece that we're working on with eNOA is a special authorization signature mapping process that they have, and they piloted it with another carrier. It wasn't a long-term care carrier as far as I know, but they worked on this process out. And really, the solution that they're solving is the whole fiasco around requiring special authorizations. As we know, for example, Kaiser always requires that special authorization, and all these boxes need to be checked appropriately, and it can be time consuming and problematic. So the cycle time on getting that special authorization takes usually right around 2 weeks. And that's from the point where the vendor reaches out to the applicant and says, hey, we need to get this authorization signed in order for us to place that order for records. And then, we get it back when we get it back. We really don't have a line of sight as to when the applicant's going to drop that in the mail or what have you. So we know that that's a pain point. On top of the special authorizations that are out there, we know that a lot of folks are using the e-apps now. And of course, with that are those e-app signatures. And those e-app signatures, unfortunately, do get rejected a fair share of the time. I think it's right around 40 to 50% of the time, which means that we need a wet signature on the authorization in order to get medical records. So eNOA has created this system, this process, and it has been worked and it's being accepted. They have a process by which they reach out to the applicant. The applicant just has to sign a piece of paper, take a picture of it, and then send that picture over to eNOA, and they'll affix it to the special authorization. I know that sounds kind of shady, but it is working, and our legal department feels that it is appropriate. So we haven't rolled this out yet, but this is another piece of process improvement that we're going to roll out. And finally, kind of the big one that we're working on right now, we started it on 5/1, is that we have a limited NeuroTrack pilot. Now, some of you folks out there who do business with Nationwide may be familiar with NeuroTrack. It is the same tool. For those folks who aren't familiar with NeuroTrack, NeuroTrack is it's kind of like a brain game. It's a tool that was created to be used in the clinical setting. It's a way of measuring cognition. And it takes about 3 minutes to do. It's like on a little brain game. You just jump on like an iPad or something along those lines. And what happens is you match letters and shapes, and you determine, based on the amount of time it takes to do these things, it can measure cognition. Now, what's really neat about NeuroTrack in of itself is that you have the ability to practice it a few times before you go live. So what we've done in this particular pilot is that we have we use it during our face-to-face assessments. It's, again, this is a limited pilot. We only have 3 marketers that are using it right now. But during the assessment, the individual conducting the face-to-face assessment will bring like an iPad with them. They'll conduct the face-to-face assessment. They'll ask those medical questions. They'll do height, weight, build, etc. You know, those vitals. They'll do the time, get up and go, and then they present the individual with the tab. And together they'll go through, here's how you do the NeuroTrack. The individual can do a couple practice runs and then they go live. And what we're finding so far is that, you know, this is working out pretty well. One of the benefits of NeuroTrack as opposed to the other tool that's used out there during face-to-face assessments called the EMST is that anybody can administer a NeuroTrack. Whereas the EMST, it's a licensed product owned by our third-party vendor, Illumifin. They own that particular test, which means that if you are going to administer that test, it has to be administered by Illumifin. In this particular case, not only are we trying NeuroTrack, but we're trying a different vendor as well to see how it works for us. So we're very excited about the results so far. And again, you know, like anything else, we're always willing to see what's out there in terms of information. How do we get it in the hands of the underwriter as fast as possible? But also, you know, making sure that it's robust and it is accurate so that we can make that appropriate decision correct the first time around. Any questions on that?
Only one question so far. I took care of it, so we're in good shape.
All right. All right, so other ways to get in touch with us, certainly underwriting pre-screen can be done at ltcunderwriting@mutualofomaha.com, or of course you can give us a holler at 800-551-2059 extension 3 or option 3. You want to make sure you select option 3. We have a number of great tools out there, some questionnaires. Some of the more common ones are the drug and alcohol one. The diabetes one is used quite a bit as well, but we also have other ones that cover arthritis, COPD, etc. We have our next steps guide, and the next steps guide really sort of provides some insight into what's going to happen. It gives you some information that you can share with your client to help them be prepared for the underwriting process. A big part of it, of course, is being that cognitive screening. And the importance of this next steps guide is really, really key based on something that just happened the other day. We had an individual that apparently wasn't aware of the fact that you know, they really should go through these cognitive screenings without having distractions around. So we had this one lady. Unfortunately, she failed her the cognitive screening. It was conducted over the phone. And in this particular case, she was in the process of moving. And during the whole cognitive screening, I listened to the call. She was interrupted several times by movers asking her what to do, where does this go, where does that go. She eventually finished the call in a closet. You can imagine she didn't do very well. One of the key elements in the next steps guide is to remind the agents out there that, hey, if your client is 60 to 79 years old, they're going to go through some sort of cognitive screening, be it over the phone or 65 and older during the face-to-face assessment. And you want to make sure that the individual is not distracted at all. We don't retest for these things. And so if the individual is going to be distracted, maybe they're moving, maybe they should schedule to schedule the interview at a different time. Or at a different location. It's not like you have to have a phone history interview. You have to be at your house. You know, I mean, certainly hope that you're not on the phone driving when it's being conducted, but at the office, at the library, wherever the case, wherever you can be in a setting that's nice and quiet and without distractions. If distractions are unavoidable, let your client know that it's okay to say, you know what, I can't do the interview right now, let's reschedule. You're not going to be penalized for rescheduling a interview like that. So again, really, I can't emphasize enough that if you know that your client's going to go through a cognitive screening, that they are without distraction. And then finally, of course, we have our underwriting LTC product guides. The new editions are coming out soon. All of that stuff is with our marketing team. They're making it nice and pretty, and we're really hoping that we have a June release for these, both the underwriting guide and the product guide. Now, I do want to assure you that the guideline changes that we covered earlier are in fact in production right now. So in other words, if you submit an application right now and your client has a family history of dementia, mom develops, dementia at age 85, we don't know why or how or whatever, you can still quote her preferred. I don't encourage people to quote preferred, but preferred still on the table. We're using these guidelines right now. Any questions?
All right. Yeah, let's open it up for questions. As I always say, and I'm getting ready to unmute folks, if you're not going to ask a question, go ahead and self-mute so that we don't have the noise that comes about when the Amazon guy shows up for the delivery of the day, or dogs barking, tea kettles whistling, et cetera, et cetera. So we're going to unmute everybody. We do appreciate everybody making your time available. One thing I will throw in, having been kind of in a wrangling position for a long period of time, Mutual's done a really good job of interjecting what I would call common sense into a lot of parts of this process, and that's been really helpful over a long period of time working with Mike, Chris, and others on their team. But it's important for you as an agent to also keep some common sense in play. And if you remember back at the beginning, and I don't have anybody holding their hand up yet or piping in for questions, it's important, if you go back to one of the slides Chris showed at the beginning with regard to the breakdown of how business gets offered out there, don't consistently throw your clients in as preferred. Okay, think it through, and if you really seriously believe they are going to be one of the 18% that warrants a preferred offer, then go ahead and do it. But don't just throw it up there. Quote preferred to make sure that the price is nice and tight for them, because when it comes back select, and it will a great majority of the time, it puts you unfortunately in a position of having to go back and ask for more money by virtue of a 15% difference in the premium. So you're far better off to quote everybody select, get the offers that do come back, that essentially 2 out of 10 that do come back as preferred, and get that. You're going to be a hero because you're going to actually tell them it costs less than what you anticipated, and pretty much everybody's happy with that outcome. When you send somebody in as preferred and they get approved select, not too many folks are happy with that particular outcome. So anyway, all right, looks like we don't have anybody with questions. We will be following up with you with some phone calls later today to see if there's questions, anything else that we can help you with. We will make the underwriting and product guides available electronically as soon as we have access to that. We'll get them sent out to you so that you have that. In the meantime, if you've got questions on any of it, of course, you can give us a call. We'll also, as part of the process on the call today, be talking with you with regard to contracting, with regard to compliance. So compliance guidelines are very clear about the fact that to offer Mutual of Omaha long-term care, or to discuss Mutual of Omaha long-term care with a prospect, you have to be through the contracting process so that the carrier can verify that you have the appropriate CE for the state that you're in, little detail pieces like that. So calling us back tomorrow and wanting to get some quotes for people that you think want to buy long-term care, and you'll take care of the contracting when it's time to write the policy, wink, wink, nudge, nudge. That's not how we do it anymore, and that's not how compliance requires that it be done. So we will be discussing the contracting piece with you as we have these follow-ups. So Amanda, Maria on the sales side, thanks for your time, ladies. Appreciate you being here with us. Mike,
Thank you, Mike.
It's good to catch up with you, buddy. It's been a long time. Glad to hear you're still with us and still plugging away. Chris, as always, appreciate what you do. You and I speak routinely on a variety of different topics, and your guidance and input and problem-solving expertise is very much appreciated. So Next week's webinar is going to be
sometimes.
Yeah, exactly. Every once in a while we actually talk about work. Next week's webinar, you were doing the Tuesday twofer with me. We will be talking about one of our great ancillary options. It's the Precision Care Cancer Policy from Guarantee Trust. Greg Exposito from the carrier will be on with me next week, 9 a.m. Pacific time. Always, it's the same bat time, same bat channel for that. So, to let everybody go, give you 3 whole minutes of your time back. Appreciate it. Thanks, everybody. We'll be in touch soon. Bye now.
Bye-bye.